and thank you for joining us for BlackDoctor.org's Cancer Awareness Summit. I'm your host this evening, Shamika Rhymes. Let me know where you are watching from and make sure to share this with your network because you never know who may need to see this. And also, if you have any questions at all tonight, please drop it in the chat. And like I said, this is part of our Cancer Awareness Summit. And tonight during this panel, we are focusing on lung cancer, one of the leading causes of cancer-related deaths. And yet it's a disease that's often misunderstood. And lung cancer affects thousands of people every year. So it's especially important for our community to be aware of the risk factors, early symptoms, and life-saving screening options. So joining me tonight, Dr. Sandy Kataya. Hi, Dr. Sandy. You're on mute, but I would like,
Hi.
hi, please
Hi,
introduce yourself.
my name is Sandy Kataya. As Shamika said, I am a medical oncologist in Baltimore, Maryland. I work in a community hospital and I treat a lot of lung cancer patients and run some lung clinical trials. And I'm excited to talk to you guys tonight about lung cancer and hopefully answer some of your questions.
Well, thank you for coming back, Dr. Sandy. Let's see, we've got Dr. Reckamp from Cedars-Sinai joining us as well.
Hello, happy to be here. I'm the Division Director of Medical Oncology at Cedars-Sinai in Los Angeles and a thoracic medical oncologist and involved in clinical research and translational research for new therapies for lung cancer.
Welcome back. And we've got Dr. Eugene Manley Jr. joining us as well.
Good evening. Thank you for having me. As stated, I'm Dr. Eugene Manley Jr., and I'm the founder and CEO of the SHEC, or STEM and Cancer Health Equity Foundation. And part of our work is increasing health literacy and running an annual lung cancer health equity summit to bring information to underserved populations to help them navigate care.
Welcome. And then we also have John and Stacy joining us tonight.
My name is John Anderson III. I'm a ROS1 lung cancer survivor, and I'm an American Lung Association advocate.
Hi, I'm Stacy Anderson. I am the spouse of John Anderson, who is a lung cancer survivor. We're located in Chicago, Illinois.
Welcome. Thank you for joining us tonight. Mm-hmm. And again, for those in the chat, if you have questions tonight, please drop them in the chat and we'll get to those. So I thought we'd kick this off with an important question here. What are some of the common symptoms of lung cancer? Dr. Reckamp, can we start with you?
So the common symptoms of lung cancer have to do with things that come from your lungs for the most part. And so coughing, feeling short of breath, those are generally the most common. If it gets more serious, sometimes we can start to have pain or things that might be associated with the brain, like headaches. And unfortunately, the reason lung cancers are often not diagnosed at early stages is because when they're early stages, we don't have the symptoms. And so these symptoms often occur when it's later in stage, but generally they're related to the lungs.
Okay. And well, over the past few years, have there been any breakthroughs that have changed how we treat and think about lung cancer? Because like you said, sometimes there's no symptoms.
So I think that's important. And because there are no symptoms, probably one of the most important things, and this has been out for more than a few years, but the uptake has been slow and low, is screening for lung cancer. And so at this moment in time, it's generally for patients who have smoking history, but we have screening that can detect early lung cancers and potentially prevent, lung cancers from being late stage at the time of diagnosis. We're looking into screening for non-smokers, but we don't have guidelines for non-smokers at this point in time. So screening is incredibly important. And then we have targeted therapies and immunotherapy that have really been groundbreaking in changing the way we treat and think about lung cancer. So even when people have later stage disease, they often are living for many years because of these treatments that we have for patients. And we're now moving these immunotherapies and targeted therapies into the setting where we give them to patients who have had their tumors taken out. So we call it adjuvant therapy or neoadjuvant therapy at the time of surgery, we're giving these therapies. And this is helping more people to be cured of their lung cancer. And really that cure is something that used to be very elusive and now is something that we can actually talk about with patients. And the ROS1 lung cancer, I'd love to hear John's story, but the ROS1 lung cancer, really people can live for many, many years on taking a pill and do very well and be in their lives. And it's just wonderful to see how people can live with lung cancer. And I think that's the biggest thing that people don't know. You can actually live with lung cancer and a very quality life.
Thank you for sharing that. Dr. Kataya, from your experience working directly with patients, what improvements are you seeing in early detection and survival rates?
I mean, I think I echo what Dr. Redkamp said. You know, my best friend actually, who's 45 and a breast surgeon, just got diagnosed with stage 4 lung cancer unexpectedly. She never smoked. And that has really personally impacted me because we've been friends for 12 years and she saved a lot of people's lives with breast cancer. But, you know, she's short of breath, coughing, was having pain that was radiating to her shoulder for a month, and she thought it was her asthma. And she just happened to have a targeted mutation. So she has an ALK mutation. So they have her on medication for that, a pill for that. But I think that, you know, in the past, we used to have chemotherapy, which we still use, but not by itself so much anymore. You know, we try to combine it with other things because the effectiveness goes up. Because chemotherapy by itself only helps 3 out of 10 patients, and it can be quite toxic. So, you know, and there are people who I have, I'm sure Dr. Redkamp also has, who have been cured of their cancer because of immunotherapy, like stage 4 lung cancer cured with immunotherapy. And that was unheard of before. I mean, you know, like 15 years ago when I started, there was no immunotherapy, there was no cure for stage 4. I just wish it was for everybody. So the research is, you know, how can we make people respond to immunotherapy better? You know, half of the patients have targeted drug options now. So we're looking for targeted drug options. So because the response rates for targeted drugs are much higher than with chemo. And if you have the right marker for immunotherapy, you have much higher response rates than chemo. So, you know, we are making a lot of progress and certainly helping people survive longer. And some people are getting cured who had incurable disease before. So I think that's very encouraging.
Thank you. And I'm so sorry to hear about your friend, but it sounds like she's on the right path.
Thank you.
Dr. Manley, your work focuses on research equity. So how do disparities still show up in who gets diagnosed, treated, and enrolled in clinical trials?
Thank you. Well, this is a wide-ranging answer. Part of this ties into the lack of representation in the workforce. So there's a lot of, you know, bias in care delivery, whether patients are listened to, whether they are offered chemo first and then, but not offered biomarker testing. Are they offered the whole panel of biomarker testing or just 1 or 3 markers? Often it's a cost issue, but then if you aren't given the full set of biomarkers, you cannot know what therapy might be out there that will work for you. So this exacerbates disparities. And we also did some work with some patients out in Seattle, and we saw that even for educated Black patients, that they still were having delays in screening and diagnosis and treatment compared to their other counterparts. And so if you translate this back to what the underserved and low income, then you know it's a much bigger problem.
Mm-hmm. Thank you for sharing that. And this question is for, I'm going to kind of go around, but Dr. Kataya, what's one common misconception about lung cancer that you wish you could eliminate right now?
Common misconception. That's a tricky question. I think that, you know, there are non-smokers who get lung cancer.
Yes.
I mean, the people are smoking less and less. And so the most aggressive forms of lung cancer, like small cell, is becoming less frequent. But there are people who are non-smokers who can get lung cancer. I think it's important to, you know, pay attention to symptoms and follow up on things. Some people get random scans for different things, and sometimes the lung nodule is found. And so it's important that as medical records are being released to patients and they have access to their records, that they pay attention to things, because a lot of times the patients will bring up things that maybe, somebody didn't follow up on, and it's important to be aware of your information so that you can then bring it up with a physician to make sure it's being followed up on. But I think that's probably one misconception, is like, if I'm not a smoker, I'm probably not going to get lung cancer, which is not quite true.
Okay. Dr. Redcamp, what about you? Is there a common misconception that you would love to eliminate right now?
So obviously the smoking piece is a big piece, because and what goes along hand in hand with that smoking is the stigma. So if you get diagnosed with lung cancer and decide to tell a friend or a colleague, the first thing they're going to ask you, or one of the first things, maybe they'll ask you how you're doing first, but one of the very first things they're going to ask you is, did you smoke? I didn't know you smoked. They'll bring up something and they'll connect you with a smoker, and then it becomes your fault. So that stigma is really problematic for lung cancer. It really prevents people from getting the help they need, often feel that it's their fault, and then feels like you can do less about it. And so there's a lot of kind of nihilism associated with lung cancer, that you can't do anything about it, and a lot of blame that comes with lung cancer. And those are the things I wish we could get rid of, and help people understand it's very treatable. People can live well with it, and it's not your fault.
I think that's huge. Dr. Manley, how about you? Is there a misconception you wish you could eliminate?
Well, since they covered that not all, that you don't have to have a history of smoking to get lung cancer, I will go with what are the other risk factors. So these include indoor cooking modules, radon, air pollution, job exposures. Unfortunately, most of these are not included in the screening guidelines. So the only way they are included is if you have an adept navigator that writes it in the protocol. But these are other risk factors in play, but they are not uncovered under the general screening guidelines.
Thank you. I'm gonna jump on this list because I really want to hear John and Stacy. John, would you mind sharing your story, like how you if you did early detection, or how did you find out that you had lung cancer?
My story is unique. First of all, this panel is dynamite. First of all, I had a shoulder injury with my job, and I'm being Mr. Stubborn. I was going to try to shake it off until I had to. And come to find out, when I had my shoulder CT scan, I had a lump in my left lung. Took the biopsy. It was what they call aggressive. They didn't know what it was. They knew it was cancer. Come to find out, it was so aggressive. I think I got my diagnosis on a Thursday. I was on the table that following Monday, and took my left lung. And I thought I was going to be okay. I went into chemotherapy, one of the treatments I went through, and unfortunately, it came back in my only right lung. And I took a couple medications. That's why I can tell people out there, this biomarker testing and this research is working. It's working, because I went through chemo. I went through one medication that just destroyed my body, my face, my shoulders, and then they had to send my specimen out. And they found out what I had, ROS1. I guess that was rare back then. This was back in 2015 when I got diagnosed. And I think it was 13. That's neither here nor there. Make a long story short, they sent my specimen out. My doctor came to me, because what happened is I told them that I went through chemo. I went through this one medication. I told them no more chemo. I told her, please, doctor, no more chemo, because unfortunately, the way it treated me, it was harsh. And my lifestyle was non-existent. And it was so cool how she said, John, give me time. She said, my specimen, and she came back. She said, John, I got something for you. And I'm saying, what? I said, no more chemo, please. And it was my medication, which is now, I've been around for 10 years now. And yes, it has some side effects. It does. But thank God, because of my DNA makeup or my cancer in my body and what's going on right now. And this was back then that I know of, at least at my hospital, it was on the cusp of becoming, used. So they didn't know what to do. That's why they had to send it out, and boom, here we are. And thank you, Dr. Redcamp. Thank you so much for your research.
Wow.
Mm-hmm.
I wanted to give the doctors a moment to weigh in on your story, John. Thank you for sharing that with us.
Well, it's an incredible story, and really, I mean, so you were diagnosed with this ROS1 before we probably even quite knew what ROS1 was, or you were diagnosed when you had your chemo. We didn't even know what ROS1 was, and then you benefited from us knowing a little bit more a few years later when you needed it. And I think that's the story of what's so important with research and the field that's moving forward. What I tell people that get diagnosed right now is you may benefit from things that we don't even know of today. There may be new drugs. And for ROS1, now we have about 5 drugs that can treat ROS1 lung cancer, even though it's a small subset of lung cancer. And so it's really quite exciting. And the misnomer, and I will have to say, just because we're on blackdoctors.org and we're talking, there's another misconception that's really important. So many of these non-smoking lung cancers, they occur in women a little more preferentially, and they occur in people with Asian backgrounds more often. And so when we see people who are Asian and women, we think about these genomic alterations. They're not always at the front of mind when we have a Black patient in front of us. And so you're a Black man, and so it wouldn't have been the most common thought. But that means just like anybody with lungs can get lung cancer, anybody with lung cancer can have a genomic alteration. And in today's day and age, you need to test everybody. And so that's an incredibly important thing, because in some hospitals, your tumor might not have been tested.
Oh, come on.
So that's a problem. And so that's something we need to improve upon. But your story is really remarkable, and it really shows you why the research is so important and the advances keep coming. And so even if there isn't something today, there may be something in a year, in 2 years, and you keep going toward that.
Can I say something? That's why Dr. Manley also, when he said about us, not getting the rights, as Black people, disparity as far as testing, that option before they do chemo. I was blessed. We worked hard and we asked the proper questions because I was tired. So I just thank God that I was one of those ones that got through. That's why I'm here. Everybody knows. Yeah, I was a guinea pig, and I thank God I went through it. But I'm here to let everybody know it can be taken care of.
Absolutely.
I just want to say, John, what an incredible story. And I'm so glad that your medication has been working for so long. We only wish for that for every patient. And I hope that you continue to respond very well for many more years. And, there, like Dr. Rekham's saying, there's mutations that occur, and we have drugs for those mutations now. So they're always trying to find ways to overcome resistance to treatment to try to keep people living longer. So cancer, thankfully, has become a chronic illness. I just want to make sure that for people who don't know what we're talking about, and maybe you guys all do, and I apologize if I'm insulting anybody, but when we say biomarker testing, we're talking about breaking open your cancer cells and analyzing the cancer cells to look for things that will open you up to treatments other than chemotherapy. So, do you have something called a PD-L1 marker that will make you more susceptible to immunotherapy? Do you have a, KRAS mutation or a ROS mutation? And, we do find it more often than we used to. The list has expanded tremendously. Back 15 years ago, the EGFR mutation was the more famous mutation that we had. And now there's so many mutations that it's kind of hard to keep track. And we have companies, if you're not in a big academic center like Dr. Rekham, but there are companies that are out there that have made it their business to do this tumor testing and to do broad range testing of the cancer cells. And then the results usually come back most of the time within 2 weeks. And we're able to come up with the best treatment plan for the patients. And it's very rare that we will rush into chemo first unless we really feel like it's going to be delayed and the patient has a lot of symptoms. We try to wait for all the testing to be done so we know what the right step is for that patient.
Exactly.
Thank you. Dr. Manley, I wanted to give you a chance to weigh in as well before I go to the next question.
They just touched on it. I was about to say, when I started my PhD way backyard. At least it was after 2000. The first thing we discovered was probably EGFR, and that was probably 2003. And there was not even anything on my radar. But just looking at where we've come in the last 20 years, as far as all the different biomarkers, we have probably 11 now, and we have therapies for them. And this just did not exist in the past. And because we're doing such a good job of screening, a better job of screening and detecting early, we are now starting to see that population of people that never had a history of smoking that was probably always existent in the past, but they just it was assumed that they had a history of smoking. So we're just making significant strides in the diagnosis and biomarker testing, and when lung cancer is driving a lot of precision medicine across other cancers.
Mm-hmm. Thank you. Dr. Kataya, many patients often delay testing because of fear or misinformation. What conversations do you have with patients to help them move past that hesitation on being tested?
I think it's very important to understand why somebody doesn't want to get testing. I mean, I have the same discussions all the time about why people won't get colonoscopies, why somebody doesn't want to get a mammogram. And sometimes it's related to, well, I just, what was one? I don't want to get put to sleep. Fine, then let's try to do Cologuard testing. Let's do some kind of screening, okay? So, because there's very few things that prevent cancer. Colonoscopy is one of them. Everything else is meant for early detection. And because we think early detection saves lives, and it does, right? So I always try to get to the bottom of it. Is it a financial issue? Is it you can't get out of work? Is it because you're afraid of being put to sleep? Is it because the mammograms are uncomfortable? So I try to talk it out, and I try to explain to them why it's important, how we can get through the barriers. And I'll try to get my social worker involved if it's a money issue. I'll try to get them to help with transportation. So as much as we can to try to figure out the reasoning behind it, because it's hard to kind of you shouldn't assume that why somebody doesn't want to get the testing. You should always ask and try to help them out. And then there's one other thing I want to make a point. We don't want people to feel stigmatized about smoking and lung cancer, but we do encourage people to stop smoking once they have lung cancer, because some people think that, well, the horse has already escaped the barn, so what's the point now? I've already gotten lung cancer. You're actually going to respond better and longer to treatment if you stop smoking, and you might prevent a new lung cancer. So it's always important, even though it's very hard, and we know that it's easier said than done, to continue to work on not smoking, or try to cut back, or try to get help to try to get away from that habit, just for your own sake. Because smoking doesn't just cause lung cancer. It can cause emphysema, which can then cause shortness of breath. It can cause accelerated heart plaques, or like plaques around the heart. So it's important to try to give up those bad habits and not feel judged. But if something's not succeeding, you just keep trying, and then one day you'll be successful. But it's more of an encouragement. It's not a judgment that, hey, how could you smoke and do this to yourself? I hope that nobody ever makes anybody feel that way.
Yeah. I just wanted to touch on something you just said. So you can get more than one lung cancer?
Well, there's a concept called field cancerization, which is when you smoke, you basically coat the throat and the upper esophagus, you coat your lungs. So, you can be at risk for developing more than one cancer from smoking, and you can get more than one lung cancer over the course of time. Yeah.
Okay. Thank you. Well, Dr. Manley, how can community partnerships between organizations like blackdoctor.org, research centers, and local clinics help close that gap when it comes to testing and treatment access?
I think this is a great question. A lot of it is you need these multiple stakeholder partnerships because they help build or build trust. You can have your trusted community stakeholders that actually are willing to listen, because often you just get told and dictated, and that's not going to work in underserved communities. Like, you have to be willing to meet them where they are. You have to use terminology that resonates with them. Like, even when we talk in lung cancer about pack year history, we say it's a 30 pack year history. You can't say that to some people in the inner city. That does not commute. So you have to figure out how to frame how they're going to interpret pack year history. So you're like, how many hits do you take? How often do you smoke this? How many packs do you go? You can't say pack history. You can get the answer, but you have to say it a different way to get the answer that you need. But I think these partnerships are really important. And I think the local clinics are critical because that's where a lot of the treatment happens for underserved populations. And if you just only go to the major medical centers, well, then you're going to isolate a whole population will never go there, or they don't feel seen there, or they don't feel appreciated. And then there's a whole, medical bias that creeps in. So I just think putting these different pieces together with trusted stakeholders and really encouraging, learning more about the disease, learning how to advocate, and really learning what to do to move forward is, I think, the best way forward. So I think these are critical.
Okay. John and Stacey, I'm coming back to you. What was the hardest part of navigating your diagnosis, John? And Stacey, what also kind of helped you be that strength for him?
What was hardest was navigating through was the, as I said earlier, was the test, the chemo, the medication, not knowing what's going on, being told there was nothing else can happen or more chemo, which, did some damage because it was so invasive to me. But it was just once I got that biomarker test and I had that medication, it rejuvenates you, And I've had like I said, of course, the side effects at the beginning, but once you learn to work with them, it got me going. And like I said, and I'm gonna tell you something too. It's so important as a patient. I'm not, you guys all very well knowledge. I'm just a regular guy. When these people go, you got to have a doctor too. You got to go to a place that's going to listen to you, and you're going to, that's not going to blow you off and see you come in and say hi and bye. So that's important too. So I'm just talking to the doctors out there. It's so important, that relationship, and to listen if you want to help someone. But that was the roughest one for me. Sorry.
I think the hardest part for me was, I'll never forget, I came home from work. It was in June 2013, and we were getting ready to go to my nephew's high school graduation. And I could tell something was wrong. And John said that he had received the call and that it was cancer. Right away, I broke down. And that's a natural response. But after that, I can honestly say I was in, you have to do this mode. You have to be there for him. And I never shed another tear. After that, I spoke to my family, made sure everybody was on board for what I needed to do for him and what they needed to do for me for support. And then in 2015, I'll never forget it. We were on the bus going to the movies. It was our anniversary, and we received that second phone call that said the cancer was back and it was in his right lung. Mind you, he only had one lung. But this time I didn't cry. But he had already told me, we had already talked about it when they did the biopsy, and he said that he would not have chemo again. And as the partner of a cancer, someone with cancer, I was supporting him 100%. It didn't matter what I thought, what I wanted. It wasn't my body. He said no more chemo. And I'm so thankful for his oncologist that they had roundtable meetings about biomarker testing. We had never heard of it until she called and said that she had fought for John. She made sure the money was there because it was a very expensive test, which we did not have the funds to do. No. And that's another issue with being diagnosed with cancer. People are scared and they don't have the money. So they fear that they won't get the results or the testing or the care that they need to survive. Proper treatment, as John says. And I was very thankful, but she never stopped. She kept pushing. And when she came and said he had a rare gene, ROS1, I like that term, Dr. Kataya, ROS1, and Dr. Redkamp. And she said, we have a medication to try. And like he said, it was horrendous for him. The side effects were horrible. But we went and told her, and as John said, I think it's very important that you have a communication with your oncologist. oncologist and any other doctor that's part of your roundtable. And she didn't stop. She said, okay, let's try something else. And he's here today because of that. Let's try something else. Mm-hmm. And the fact that we spoke up and said, I know this is supposed to help us, supposed to help him, but the side effects are too bad. We're just going to stop. We were willing to take that risk, but she went a step further. And that's why we're where we are today.
Thank you for sharing. This is such a powerful story that I think the audience definitely needs to hear. And I'm going to pause and let the doctors weigh in on what you just shared as well. Dr. Reckham, how about you?
So I really do appreciate your telling your story because it exemplifies the whole journey of it. It's not one moment in time. It's multiple struggles. It's going through all the emotions. When you get a diagnosis of lung cancer, it's like you've been hit by, a Mack truck like that. And not just the patient, but the caregivers and the support staff and all of the family members. Everybody feels it, and everybody feels it in a different way. So just to hear your story and your journey through this is, I think, really important for people to understand. And there's highs and lows, and there's difficult times. But yet here you are. And one of the questions I just love to ask, so what is it that you like to do with your free time, and what are you doing? You from this little view of you, you look really quite well. And so I'd love to hear what you're enjoying in your life and what this progress we've had made in lung cancer has helped you to be able to enjoy.
First of all, it was a blessing in disguise because I'm advocating for everyone, but especially for men of color. But the other thing was that all I do is travel now from Indiana, Minnesota, Wisconsin, Chicago. I'm a father, I'm a grandfather, I'm a great grandfather, I'm a supporter, I'm a brother, I'm an uncle. That's what I'm doing. I am getting in touch with my family because when I was working and when you're sick, you really, you realize what's really what's valuable and what really means something to you. And we see each other constantly now on the phone. We go to, I'm just on the road, baby. That's how it's blessed me. But it wasn't hard. But that's why I got to advocate for other people so they won't maybe go through what I went through, because I do have some problems because of the chemo, Mm-hmm. But it's been everything is fine right now. But that's why I want to tell people that don't know, especially men of color, don't be afraid. Come on out. And Miss Dr. Manley, I just want to say thank you for what you do.
Thank you. Oh, God. Thank you. Don't put me on the spot like that.
Yeah, tell us what you did.
Oh my God. I do a lot of education. Like my PhD is in lung cancer, but I do a lot of information and resources and research about lung cancer disparities. I do the annual Lung Cancer Health Equity / Intervention Summit, which John attended. I don't know if you attended both days or just one day, but this is an event where we bring together patients, caregivers, and survivors want to learn more about the disease, learn more how they can advocate, and learn who is working on their behalf, either locally or nationally, because maybe they can refer a friend to a doctor that might listen to them, like he just mentioned. But in the other part of this is we bring together researchers, clinicians, payers, hospital systems, surgeons, pulmonologists that are all diverse. Not everyone is, but we bring diverse stakeholders in to not just talk about the problems underserved communities face, but what different types of solutions people are creating that are actually removing the barriers, removing the disparities, and or improving outcomes. And by collectively having patients, researchers, clinicians in the same space, you break down these silos. And so it kind of makes the researchers and clinicians bring heavy science down to an understandable level for the patient. And then you really get this ecosystem that really helps everyone along. And then one of the other patients came up to me at the end of the conference crying that she had never seen a conference like this and never seen so many Black people in the same space, and that they were all down to earth and relatable. And so that sort of reinforces why I try to do the summit.
Okay.
And I think one important piece too is that we know all of these advances have been made because of clinical research over the last 20 years. And what we also know is very few Black patients enroll in these trials. And there's lots of reasons that are behind that. But some of the research shows that if you ask a patient, regardless of race, if they want to be on a trial and they're eligible, they often say yes, not at a differential level. So there's something about that ask that we're not doing. And so that's important too. And that's something that we are, Eugene and I have worked together and trying to pull things together. I work as in our National Cancer Institute consortium, our cooperative groups, where we have trials that open across the country, including at community sites. And when we open these trials across the country, community sites that may have more underrepresented groups, we do see that we increase that percentage. And we just finished a trial last year that had we tried to open up the eligibility to make it make as many people eligible as possible, make it as easy as possible to get in. We finally got to 14% of the population in the trial were Black. So that basically matches our US population. But I think it's the first trial I've seen like that. Usually it's 1%, less than 1%. So we need to do better, because what we also know is that there are biological differences that we are never going to learn about if we don't study specific races and ethnicities.
Right.
And so we need to do better, and we need to have a conscious effort to include Black patients and all patients in the trials that we're doing. And that's something that has not been done. And still to this day, especially for biomarker driven, so these oncogene driven cancers, very, very few Black patients have been studied with these. So you talked about side effects that you had initially even with the oral drugs. We don't know a lot about how they're going to affect you, because there aren't a lot of people like you that were tested in the clinical trials.
So how would you convince someone that is hesitant about joining a clinical trial? What would you say to them? And this is for both, Dr. Sandy and you, Dr. Reckamp. What would you say to get them to maybe, be open to it?
I was going to say, John, there's a couple of things that you said that I want to kind of address. One of the things that you guys brought up, which is very important, is biomarker testing used to be very expensive. And, sometimes we had problems getting it reimbursed. But nowadays, there are companies like Harrison Foundation, and they promise not to balance bill the patient. So they try to appeal to the insurance companies. And if there are patients who don't have insurance, they try to charity some of the cases so that people can get the testing and not have to pay money or pay out of pocket for it. The second thing that you said that was very important, I don't know how Dr. Reckamp feels, but I feel like she probably feels like I feel. We don't enjoy giving people chemotherapy. We don't enjoy giving people side effects. But yet somehow we've become the experts at managing side effects, because we induce a lot of side effects. And it's very important for there to be trust between the patients and the doctors, that we're trying to help and we're a team. And sometimes we're going to try something and it's not going to work the way we want, or there's going to be a complication. And it's better to talk about it and figure out how we can get around it, or take a break, reduce the doses, give you something to help manage some of the side effects, because our goal is to help you maintain your quality of life to the highest extent. And sometimes I've had people do well with chemo, not do well with a targeted pill. Everybody's different, but side effects are always a potential thing, and it's hard for us to know until somebody tries. The other thing is, the other population where we see a lot of disparity is breast cancer in Black women, where Black women have very different, more aggressive cancers, even though they're less common in Black women versus white women. But somehow when Black women develop breast cancer, it's the ugliest form or the most resistant forms. And only about 1 to 3% of Black women enroll in clinical trials. And of course, I live in Baltimore, where Henrietta Lacks was, seen at Hopkins, and her cells were taken without her knowledge. And then there's the Tuskegee trial. So there's a lot of history with the Black population where they were experimented on, or things were happened to them without their permission, without their knowledge. And that sets up a lot of distrust through generations. But I think that if you sit down and you explain to the patient, listen, you're not going to get placebo. There's no such thing on cancer. You're not going to get some sugar pill. You're going to get an active form of treatment no matter what. And you're going to get a standard of care treatment, but we're trying to see if something else that we add is actually going to make things better. And yeah, you might not know for a while if whether what you did helped somebody else or helped you, but it's important because if you want to help future generations, then we need you to help us get through these trials and understand why the cancer is different in you than somebody who's white or somebody who's Chinese or somebody who's, Middle Eastern. Like, it's all these things are important so that we can become better doctors and help you guys get through treatments in the safest way and get the best treatments.
And it's funny that, I'm sorry for cutting you off, that you mentioned that. I am part of the research. They take my blood every time I go, and I told them, you better take my blood. So I am trying my best, and I hear you, but it just depends upon the person when it comes to certain treatments. That's why it's so good now. We have so many options, so many different tests that can kind of, cut it down some. So yes, thank you.
Yeah. Gosh, this conversation, the time has gone by so quick. So I'm going to wrap this amazing conversation up. I wanted each of you to kind of give a takeaway that you want the audience to grab onto from this conversation. I'm going to start with you, John and Stacy. What do you want people watching to remember from this conversation, or maybe something we didn't get a chance to mention?
I would like people to know that cancer, the C word, it's a scary word. It's a scary part of life, but there is hope out there. And I'm sitting here with living proof that there's hope and healing.
Amen.
Thank you.
Well, I hope people get doctors, caregivers, all you guys, everyone, is that there is hope because of this panel. I've heard some stuff, and I heard some stuff going to this young man's seminar and hearing everybody's view, but we gotta, I pay for my patience. I really want this to get done so well, so fast, so quick. So I just want people to know that the people are working on it. So, we're working on to have some trust.
That's great advice. Dr. Manley.
I wanted to touch two things, and I'll try to keep them brief. One, we didn't really touch on menthol in Black communities, and typically, the reason it's a lot of Black patients show up with lung cancer that's diagnosed at earlier ages, but at later stages. A lot of this is the history of menthol, and what people don't understand is, a lot of people think, oh, well, menthol, it's better, cigarettes are better for me, but what menthol really is when it's inhaled, it cools the lungs, so it masks the searing heat from the tobacco. So a lot of Black folk think, oh, these are better because I got my Black amounts. I'm like, no, they are not better. It's much worse. And so also what happens is then you have nicotine, which is addictive, and then you add the menthol, which is sweet, and it makes it that much harder to break the habit. Really, really that much harder. And so I think about 80 to 90% of menthol, 90% of Black patients that smoke cigarettes smoke menthol flavored cigarettes. And that is factual. And the other thing is we touched on the clinical trials, but we sometimes miss the upstream stuff, which is what do we have as patient samples. And, I did some work and we looked at the 800 cell lines we have in lung cancer. We only had 31 only 31 lung cancer cell lines from Black patients. Only one was a non-small cell line. The bulk were Asian or white males. And then of the cell lines, it was about 3-to-1 male cell lines to female. In the Asian subset, it was 7-to-1. So we have no Asian, Hispanic, we have no Native American, we have no Alaskan Native, we have no other Pacific Islander cell lines. So if that's our starting materials and that's where all our drugs and therapies and biomarkers are developed from, then of course we're going to continue to exacerbate disparity because we don't even have the samples that reflect the patients with the disease. So we have to really think not just in terms of what are we doing upstream or gathering samples and trying to work with patients to get them involved.
Thank you. Dr. Reckamp, how about you? What is something you want the audience to take away from this conversation?
So I think one of the biggest things is the progress that we've made over the last 2 decades really comes from patient engagement and the clinical research that has been done. And as has been mentioned by John and Stacy, developing that trust in your physicians and looking for what the next thing might be and having those conversations is going to be really important, because where we are today, we will be in a better place in a few years. And so being a part of that, and even if it's scary, being a part of that may improve your life. And so understanding that being a part of research is not what it used to be, and really can help move the needle forward and can be beneficial for many people. And you will help other people behind you get the benefit of that research too. And lung cancer is a treatable disease. People can live with it. They can live well with it. They can live their lives with it, and they can live for many years. And so not something to be afraid of or ashamed of.
Thank you. Dr. Kataya, how about you?
So I'm going to take a step back and sort of talk about one of the most important things when people hear the cancer word, which is your mental health. Your mental health. It's great to know the facts. It's great to know the data. It's great to know the science. It's great to know that we have more hope. There are still people who die sooner than we want and suffer more than we want them to suffer. And your physical health and your mental health are very much tied together. There is a young neurosurgeon who died of lung cancer after a few years. He fathered a child. His name is Paul Kalanithi. He wrote a book, When Breath Becomes Air. And that book was about living your life and that it's easier said than done, but living in the moment. Don't live in the past. Don't live in the future. It causes anxiety. Live in the moment, enjoy your life as much as you can, because that's how you win the battle against cancer. Sometimes you're in a waiting game. You're waiting to see what the treatment's going to work. You're waiting to see whether your scan's going to look better. It is very, very scary and anxiety producing and depressing, like what my friend is going through right now. She has 3 kids, and the youngest is 2. And, and it's a battle, and you have to get help with your mental health if you want to live your best life, not just get help with your cancer and the treatments that we're going to give you, but try to get help with your mental health so that you can still enjoy your life as much as you can. That's my biggest message.
Thank you. That is something that I was going to mention earlier, that because we didn't get a chance to talk about that. So that means we'll just have to do a part 2 to this panel at some point, I think, because we definitely should talk about that. Well, I want to thank you all for taking the time out to join us for this, informative panel. And for everyone, check out blackdoctor.org for articles and resources on lung cancer and everything we talked about tonight. And stay tuned, because the blackdoctor.org Cancer Awareness Summit continues. Coming up next in about 10 minutes, we have our last panel of the evening about multiple myeloma. So that's another crucial conversation you don't want to miss. So have a wonderful evening. Thank you again for joining us.
Thank you.
Thank you for having us.
Bye.
Bye.
Thank you.
Bye.
Bye.
All right, bye.